Hello, dear doctors. Welcome back to my channel, The Tooth Saga. I am Dr. Shaina, your friend and confidant in this journey of learning. We try to make learning dentistry a fun and enjoyable experience for you. Before we begin, don't forget to press the bell icon so you can receive notification when I upload a new video. Like, comment, share, and subscribe. Today we are going to discuss about avulsion and its treatment replantation. It is a very important topic for academic as well as practical point of view. So let's get started. Now what is avulsion? It is a complete displacement of a tooth from its socket in alveolar bone owing to trauma. So whenever there is a trauma directed towards the socket, and there is a complete displacement of a tooth from the socket, that is called avulsion. And the treatment of choice in case of permanent teeth is replantation. We should note that we should not do the replantation in case of the deciduous teeth because there's always a risk of damaging the permanent tooth germ. Prognosis of replantation will depend on action taken at the place of injury and immediate treatment after the avulsion. So we should always remember that जिस place पे injury हुई है वहां पर जो action लिया जाता है and कितनी जल्दी after the avulsion we provide the treatment to the patient, उस पे prognosis of the replantation process depend करता है. As I have mentioned earlier, the treatment of choice for the avulsed permanent teeth is replantation. What is replantation? It is the insertion of a tooth in its bony socket after its complete avulsion resulting from the traumatic injury. Now, when a traumatic injury has resulted in the complete displacement of a tooth from its bony socket, and when we insert that similar tooth in the bony socket again, that process is not known as reimplantation, or it can also be referred as reimplantation. Now, there is another term associated with the replantation, that is intentional reimplantation. Just take a look. What is intentional reimplantation? Is the intentional removal of a tooth and its insertion into the socket after orthograde obturation and resection of the root tip, or resection of the root tip followed by retrograde obturation and operation usually limited to posterior teeth. So basically it is an intentional removal. We intentionally remove the tooth and then we, after proceeding with the RCT, we insert the tooth back into the socket, and this operation is usually limited to the posterior teeth. Despite an uncertain prognosis, reimplantation is still worth a try in children and young adults whose jaws has not yet attained maximum growth and development, where a replacement would be difficult, and when the psychological impact of loss of the tooth may cause irreparable loss. But still, there are few cases where reimplantation is contraindicated, like in severe caries tooth, when there is severe periodontal disease associated with extensive mobility, when the patient is non-cooperative during the procedure, and if the patient is suffering from medical condition like cardiac uh, condition. Now let's talk about the treatment. Treatment starts from the place of injury. The minute the tooth get displaced from the socket. Remember, every minute is very important for the good prognosis of reimplantation. Now the first step is to keep calm. You have to make the patient calm and give a call to a doctor. Not only the doctor will guide you about the step you should carry out at the place of injury, but the doctor will be well prepared before the patient reaches the clinic. Remember, time is very important to save for the good prognosis. Now what next? First, we have to make sure that the tooth is the permanent tooth and not the deciduous. And now if the tooth is fallen in the ground or road, then we have to find and pick the tooth from the crown. Remember, from the crown and not from the root. Why not from the root? Because we have to preserve the vitality of the root surface. Now, if the tooth is dirty, Wash it briefly, maximum for 10 seconds under cold running water. Please note, do not scrape, brush or remove any of the root surface for the reimplantation procedure to successfully take place. Now, after the above procedure, we should encourage the patient or the guardian to reimplant the tooth back again in the socket. Why in the socket? Because the best storage medium for maintaining the vitality of the root surface cell is the tooth socket. Once the tooth is in its place, ask the patient to bite into the napkin to hold the tooth in its position. Now, what if reimplantation is not possible at the site of injury? Due to some unknown reason, the guardian or the patient attendant is not able to replant the tooth in its socket back, then what we should do? We should place the tooth in the storage media and immediately reach out for dentist. The storage media which we use are milk, and the tooth can also be transported in the mouth by keeping the tooth inside the lip or cheek. But if the patient is very young, he or she may swallow the tooth. Therefore, it is advisable to ask a patient to spit in a container and place the tooth in it. The other medias which we can use are tissue culture and transport media. The Hank Balance Salt Solution. Now, what is Hank's Balance Salt Solution? It is composed of inorganic salt and supplemented with glucose. The solution is buffered with phosphate and maintain a physiological pH and osmotic pressure to keep the cell viable. Then we can also use saline, and least we should avoid it, but least if any other storage media is not available, then we should keep the tooth in the water and reach out for the dentist. So on reaching the dental clinic, the doctor will look out for any medical history of the patient, the severity of injury, and the condition of tooth and socket. As we already know that the prognosis will depend on two very important factors. First is the degree of damage to the periodontal ligament cell due to trauma, and the second one is the length of the time the tooth is out of the mouth, which will result in the dehydration and death of the cell. So it is very important to assess the condition of the periodontal ligament cell. Now we will assess the three conditions. Periodontal ligament cell are more likely to be viable or live if the tooth is replanted immediately by the attendant or the patient, or the short time after the injury the treatment has provided. Now the second case, PDLI viable but compromised. In the two conditions where the PDLI compromised is the tooth kept in the storage media and the total dry time is less than 60 minutes. And the storage media which we use to keep the tooth is non-physiological, or the total dry time become more than 60 minutes, then the periodontal ligament cell are not viable, and in this case the prognosis is very uncertain and poor. Treatment for Avul's permanent tooth with closed apex. Now, in first case scenario, if the tooth has been reimplanted before the patient arrival at the clinic, now in case what a doctor will do, the doctor will leave the tooth in its place. The doctor will not change or take out the tooth again or anything like that. He will clean the area with the water spray or saline or chlorhexidine very gently. If there is any gingival laceration present around that area, then doctor will suture that area. The doctor will verify the normal position of the reimplanted tooth clinically, as well as the doctor will take a radiograph to see the condition of the socket and if there any periapical pathology associated with the tooth or something. Then the doctor will apply the splint for 2 weeks. Antibiotic and anti-tetanus therapy should be given. The first choice of antibiotic is tetracycline, but if the patient is allergic to tetracycline, then amoxicillin can be given for the first week. For anti-tetanus therapy, the patient is referred to the physician within 48 hours. The patients are given instructions about what should be done and avoided after the splinting procedure has taken place, and the initial RCT can begin after 7 to 10 days after reimplantation and before the splint is removed. Now, second case scenario. If tooth has been kept in storage medium or stored dry, the extraoral dry time has been less than 60 minutes. Then the dentist will clean the root surface and apical foramen with saline and soak the tooth in isotonic salt solution for 15 minutes. Why? To revive the cell if they are still alive. Local anesthesia should be administered. Irrigate the socket with saline. Less manipulation of the socket is better for the better prognosis for the reimplanted tooth. Now, the dentist should use light irrigation and gentle aspiration to remove any blood clot present in the socket to permit reimplantation. We should not curette or vent the socket. We should not make any surgical flap unless bony fragments prevent reimplantation. But after reimplantation, manually we can compress the facial and the lingual bony plates. Now, we should, after treating the alveolar socket, we can reimplant the tooth slowly with slight digital pressure. Now we verify the position of the tooth. We apply the splint, antibiotic and anti-tetanus therapy is given. Patient are given instruction and RCT should be initiated after 7 to 10 days after reimplantation as I have already explained earlier. Here you can see the process of reimplantation taking place. Now the third case scenario, where the dry time has become more than 60 minutes or any other reason suggesting that the cell present on the root surface are become non-viable. In this case, the dentist will remove the attached non-viable soft tissue from the root surface carefully. Then the root canal treatment of the tooth can be carried out prior to the reimplantation, or it can be done after 7 to 10 days later. All the procedure remains the same what we I have discussed in the previous two cases. The tooth should be stabilized for 4 weeks using splints. Note, to slow down the osseous replacement of the tooth is treated with 2% sodium fluoride solution for 20 minutes before the reimplantation procedure. Now let's talk about the treatment of Avul's permanent tooth with open apex. We are going to discuss that under the same three headings. We have discussed the treatment with closed apex. Now the first condition is if the tooth has reimplanted before the patient arrival at the clinic, and if the dry time is less than 60 minutes, and the third condition is if the dry time is more than 60 minutes. The procedure is same as we have discussed before for the closed apex. Now, what is the goal behind reimplanting the still developing teeth in children? The idea is to allow revascularization, that is apexogenesis. Now, what is apexogenesis? It is a physiological process of root development in vital infected tooth. And if this do not occur, then the root canal treatment is recommended. We should monitor the teeth every 4 weeks with a pulse test and a radiograph. Now the ideal outcome is the revascularization or the apexogenesis which occur over the next 12 to 18 months. The alternate outcome will come like we can initiate apexification. Now what is apexification? It is the method of inducing development of root apex in an immature pulpless tooth by formation of osteocementum or other bone-like tissue. So apexogenesis is for the vital teeth and apexification is for the apexification is for the non-vital teeth. Now in the case in the alternate outcome, we will initiate the apexification with MTA or calcium hydroxide or root canal therapy if clinical and radiographically we can see any pathology that is present. Now let's talk about splinting and the splint used to stabilize the tooth in the bony socket. The splint can be composed of acid etch resin alone or with soft arch wire, orthodontic bracket with wire arch, or large monofilament fishing line. We should leave the splint in place for 7 to 10 days, ideally for 2 weeks, if no bony fracture are present, or longer if necessary. The splint should ideally be placed on the buccal surface of the maxillary anterior teeth because of these two reasons. First, to avoid occlusal interference, that if we place it on the lingual surface, then while the teeth are closed, then they will interfere with the occlusion. And second is to enable the lingual access for the RCT. Here you can see and get some idea about the different kind of splint we use to stabilize the teeth in this process of reimplantation. Now, when we should do the RCT after the reimplantation procedure? Immediate reimplantation without endodontic treatment of the avulsed tooth reduce extraoral time, which is good for the prognosis of the procedure. If RCT is needed, the ideal time for the treatment is 7 to 10 days after the reimplantation procedure. Calcium hydroxide is recommended as intracanal medication for up to 1 month, then followed by the obturation with the acceptable and the appropriate material. So after removing the pulp tissue, we should fill the canals with the calcium hydroxide and leave it for 1 month, and then we should obturate it with gutta percha. The intracanal medication of the reimplanted tooth, which is calcium hydroxide, should be delayed until the first week after reimplantation. Now, the use of calcium hydroxide should be delayed until the first week. Why? To prevent the calcium hydroxide from adversely affecting the vitality of the root surface cell, and the endodontic treatment can be completed within the 6 months of the treatment. What are the instructions we should give to the patient after the treatment? We should ask the patient to avoid any kind of participation in any contact sports like football, hockey. Soft diet up to 2 weeks. The patient should be strictly put on the soft diet for upcoming 2 weeks. The patient should ask to brush his or her teeth with soft toothbrush and use chlorhexidine 2.1% mouthwash rinses twice daily for 1 week. A careful follow-up is required in reimplanted tooth after every 1 month, 3 months, 6 months, 1 year, and yearly after that to build a good communication with patient and guardian to ensure the possible outcome of treatment. In children and adults, it is frequently seen that the reimplanted tooth is followed by ankylosis, which is frequently associated with infraposition of the tooth in the oral cavity. Sometimes we have to do the decoronation, that is to remove more than 1 mm of the coronal crown portion to correct this infraposition of the teeth. Now let's discuss the favorable outcome of the reimplanted tooth. First, we are going to see in the tooth with the closed apex. The tooth will be asymptomatic, the mobility will be negligible or there will be no mobility. The percussion sound will be normal. There will be no radiographic changes will be seen, like there will be no sign of any kind of resorption or any kind of periradicular ositis, and the lamina dura will appear normal. Now, what are the favorable outcome in the open apex tooth? The tooth will be asymptomatic. There will be a normal mobility, normal percussion side. There will be a radiograph evidence of the continued root formation. And sometimes the pulp canal obliteration is accepted. Now let's talk about the unfavorable outcomes of the reimplantation tooth. Now first we are going to talk about the closed apex tooth. The tooth will become symptomatic, or it will become excessively mobile, or there will be normal mobility but with high pitch percussion sound indicating towards the ankylosis of the tooth, or there will be the radiographic evidence of resorption. In case of the open apex, Similarly, the tooth will become symptomatic. There will be excessive mobility or high-pitched percussion sound suggesting ankylosis, and the radiograph will show absence of continued root formation. Thank you for watching. Kindly share your feedback and keep smiling till we meet again.